Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing alternative approaches to anesthesia. Drugs commonly used for pain relief, like opioids and sedatives, can be very powerful, but can also lead to problems with heart and lung function and can be highly addictive. Thankfully, other ways of reducing pain associated with surgery can not only decrease problems like this, but improve overall recovery. My guest is my colleague, Dr. Joseph Marino. Dr. Marino is Senior Vice President of Northwell Anesthesia and an Associate Professor of Anesthesiology at the Zucker School of Medicine. Joe, welcome to Well Said.
Thank you, Ira.
So it's become my custom to ask all of my guests how they've been doing through this protracted pandemic. So how you been?
Everything is good. Thank God we're experiencing a milder version, and all is good, all is healthy, and the anesthesiology community is also grateful that, first of all, we're working, and second of all, the patients that we're taking care of are nowhere near as sick.
That certainly seems to be the case, and much to be grateful for there, as you said. So let's talk about anesthesiology, and specifically anesthesia in the context of surgery. I think we tend to take it for granted that if we're going to have an operation, we're not going to feel anything while the surgeon is working on us, but that's a relatively recent phenomenon in like the history of the world, right?
It is a relatively recent phenomenon in the history of the world. If you go back, and we're not talking about a long time, but if you go back as little as 100 years ago in the big picture of civilization, that's not a long time. We didn't have much. We had alcohol, and we used to drink a lot before a procedure.
Not the anesthesiologist, the patient.
The patients. Well done. Yes, and well said.
But kidding aside, I mean, when was it that anesthesia or the ability to do painless surgery really became widely accepted or utilized?
My guess is in the last 60 years, when we started with ether anesthetics and the development of the newer halogenated anesthetics. Really, it started back in 1846. That's when, modern medicine states that the first anesthetic was used at Massachusetts General Hospital. But really, that was the open drop ether technique, and albeit it was painless and it was an anesthetic, it was dangerous. And when we now talk about anesthetics providing really good care, we're talking about safety as well as painless surgery.
As you said, that's a much more recent phenomenon.
I would say that's in the last 50 to 70 years, yes.
Yeah, fascinating. I think most people associate surgical anesthesia with being sort of knocked out or totally asleep for surgery, but that's really not the whole picture, right? Tell us what kind of approaches you have to choose from for surgical anesthesia.
So it really comes down first and foremost to patient preference. We do have really four options. So if a patient is coming in for a really extensive surgical procedure, we could give them intravenous sedation, medication to just relax, sedate, and allow them to be comfortable while the surgeon is performing a minor procedure. If the procedure is considered a little bit more than minor, then we either have to go to what's considered a general anesthetic, a full body sleep process, or what's really made anesthesia not only exciting in the last 20 years, but it has created a revolution of sorts, has been the advent of regional anesthesia, whether it be epidural, spinal, and peripheral nerve blockade, blocking individual nerves that supply individual parts of the body without having the need to put the entire body asleep.
Okay, so we're going to talk more about that, but I just want to ask a question based on what you said a minute ago about sort of minor procedures versus something bigger. Could you give us an example of what you mean by a minor procedure that could get done with just sedation without the regional or general anesthesia?
Sure. We have a phrase, the removal of a lump or a bump. So if somebody comes into their surgeon's office and has a cyst or has, a very small growth on their skin, the surgeon can literally give the patient a little bit of Novocaine to the area where the cyst or growth is, and the anesthesiologist can, by the patient's side, administer a little bit of a sedating or relaxing medication where the patient is simply relaxed, not fully asleep, and, if you will, enjoying the experience.
Okay. And then the surgeon puts something locally in the skin, much like the dentist would in the mouth, to dull just that local area.
Exactly. That common term called a Novocaine or a numbing medication. Yes.
Yeah. Now, you also said that a lot of the choice about whether you, for a bigger procedure, the choice about whether you put somebody to sleep under general anesthesia or you use one of these more novel techniques of anesthetizing a particular part of the body is a patient choice. I suspect that a lot of people listening would be surprised to hear that. Isn't that like why you went to medical school, to kind of make that decision?
Yeah, it's an excellent point, but really it comes down to what we'd like to consider a partnership. So there may be an anesthetic that I feel is quote unquote better for a patient, but a patient may look at me and say to me, "Hey, Dr. Marino, I really just want to go to sleep. I don't want that nerve block. I don't want that epidural. I don't want that sedating procedure. I want to be totally out." And if that's the patient's wish and that's what they consent to, I, as the anesthesiologist, need to abide by the patient wishes and create an atmosphere and an environment that is optimal.
Okay. Fair enough. I like that idea of a partnership. So you kind of spell out what the options are, what works for the surgeon, what works for the kind of operation the patient's having, and the patient ultimately makes the call.
Correct.
Yeah. So let's talk about each of those others categories. So you said sedation for the small lumps and bumps, but then for the bigger cases, and we're talking here everything from like doing heart surgery to working on somebody's knee, right? I mean, everything else. Yeah. Okay.
Correct.
So talk to me about what's involved with what you would call general anesthesia, the kind of putting somebody to sleep kind of anesthesia. What's that?
So
how does that work?
Yeah, a general anesthetic is that type of anesthesia where the anesthesiologist will administer some medications through the patient's intravenous line or the IV. The patient will then become unconscious or totally asleep, and during the surgical procedure not feel any pain, not move, or they would be totally muscle relaxed, and most importantly of all, they would have amnesia or no recall to the effects of the anesthetic or the surgical procedure. And part of that anesthesia cocktail, if you will, includes not only to keep the patient unconscious or asleep, but will also administer pain medication, which will start to work so that when the patient wakes up, they will be pain-free after the surgical procedure, and anti-nausea medication as general anesthetics, as well as the pain medication, can sometimes cause the patient to become nauseous, and we have to proactively look to address that. And we also give a standard anti-nausea cocktail as well as part of that general anesthetic regimen, if you will.
Okay, so that's general anesthesia, and you said there were two other kinds.
Yeah, so we kind of put spinal and epidurals in the same bucket. Those are what we call regional anesthetics, and spinal and epidural anesthetics are those kinds of anesthetics that are not general anesthetics. They numb an entire part of the body, the entire lower half of the body. We typically perform that type of an anesthetic for a joint replacement procedure, or in our female population, in patients having a cesarean section, they would frequently get either a spinal or an epidural anesthetic. This way they could stay awake for the birth of their baby, not feel anything at all, and it's simply a pinch in their back, the placement of that Novocaine drug that we spoke about before, and then its actions allow the lower half of the body to be totally numb, and it reduces the ability for us to have to administer that general anesthetic medication, which has the side effects of making the patient groggy.
Okay. You have even more refined techniques where you're not putting like half the body to sleep, but you're just putting like a part of the body to sleep.
And this is where you heard me use a term revolutionize before. So the field of anesthesia is consistently evolving, like all other fields of medicine are evolving. And really, in the last 25 years, we, anesthesiologists, have experienced, if you will, a renaissance of sorts. In the old days, and I'm not really talking a long time ago, 30 years ago, we really just had the epidural, the spinal, or the general anesthetic. Mm-hmm. Really, in the last 20 years, because of the work of some really smart individuals, individual nerve blocks or the placement of Novocaine to the nerves that supply certain parts of the body has evolved as a very, very impressive anesthetic technique. So if somebody comes in for shoulder surgery, we could place Novocaine to those nerves on top of the shoulder, numb the entire shoulder and arm, and reduce the amount of anesthetic medication the patient needs to take. It's an extremely high satisfaction perspective from the patient standpoint, and it's required a lot of technical expertise from the anesthesiologists in our field to learn how to perform those procedures. And the revolution that I spoke about a couple of seconds ago happened because of the advent of the ultrasound machine.
Okay, so before we get to ultrasound, why is this better? Why is it so much more satisfying for a patient having shoulder surgery to get a regional block that numbs their shoulder and arm than to get knocked out and wake up in the recovery room?
It's really simple. It's less medication. So when we give somebody a general anesthetic, we're, if you will, making their whole body go to sleep. And that patient wakes up groggy afterwards. And because they had a surgical procedure, there is the anticipation of pain to the area that was operated on. Mm-hmm. We have to give them some pain medication, which is fraught with some side effects as well. When I
Okay.
give them a nerve block, that entire part of the body is now numb for a significant period of time, I would say up to 24 hours. That reduces the ability for me to have to worry about pain medication, and all the other side effects of the general anesthetic like grogginess and nausea and itching that we typically see.
So you're getting a head start on the postoperative pain management, and you're having fewer complications of the surgical anesthesia itself.
Excellent
Yeah.
way to put it. Yes.
So tell us how you do this.
So there's this machine. We used to use this poke and hope approach.
That doesn't sound good.
So anesthesiologists, and the reason why we're subspecialists, we would train to learn and memorize the anatomy of the body. And yes, we would get a patient that would come into the operating room, and if we were having a procedure on the shoulder or a procedure on the knee, we would poke that part of the body, place a very small needle tip, inject the Novocaine, and essentially hope that that part of the body would be numb. And by the grace of God, most of the time, because of our expertise, we got it right. But there would be, and this is the truth, a small percentage of patients where the Novocaine would not cover the nerve, and we would get either no block or a partial block and then have to put the patient to sleep. We obviously wouldn't start the surgery unless we proved that that part of the body was numb, and if it didn't get numb in the appropriate amount of time, we would have to put the patient to sleep. Now with the ultrasound, we're able to see not only the needle tip under the ultrasound waveform, but we're also able to see the Novocaine, the local anesthetic, float around the intended nerve, and our success rate of nerve blocks, as you could imagine, has increased significantly. And not only that, but our complication rate has also decreased significantly as a result of the ultrasound.
And let's just, for sake of completeness, talk about what some of those complications might be.
So the complications, pretty simple. So we want to place the needle tip just outside the nerve. If we touch or nick the nerve, we could have a temporary nerve damage. It usually takes about 6 months for that small little nick of the nerve to heal itself. And there are cases, albeit very, very rare, of permanent nerve damage as a result of that needle tip hurting the nerve. And again, may I say, the ultrasound has significantly reduced the concept of those two issues from happening.
Okay, so nerve damage, that's the biggest potential downside? Are there others?
That's the biggest. The other potential downsides, which are, statistically unlikely and very, very rare, are the chance for infection. We don't really see that published in our literature. And the other, possible side effect is, the nerve is an area of the body that's surrounded by some blood vessels, by either a vein or an artery. The intention is for us to place the needle tip just outside the nerve, but if that needle tip were to enter a vein or an artery, and if we were to inject the Novocaine into that vein or artery, there would be some unwanted side effects. They would not be highly morbid, but there would be some side effects that we would have to treat immediately afterwards.
Yeah. Yeah. Now you said that something else that I thought was kind of interesting, that the nerve blocks that you're doing regionally with the technique that you just described, make the area numb, but it also kind of paralyzes the area, doesn't it?
It's one of the patient side effects that we have to do a really good job of communicating beforehand. Hey, Mr. Smith, you're not going to have pain for up to 36 hours afterwards, but I also need you to know that your extremity, your arm, your hand, or your leg, whichever the body part is that we're going to numb, is going to be really numb. You can't move it for, up to 8 hours. I just want to make sure that you're aware of that. After the surgery is completed, sometimes that feeling of numbness is perceived by the patient as uncomfortable, and they really are waiting for that numbness to wear off so that they could regain feeling in that body part.
Yeah, I unfortunately have had some personal experience with this recently. I had some surgery on my foot, and I had a nerve block in the lower portion of my leg. And it was great in the sense that I didn't feel any pain. But as you said, it was very weird that I couldn't wiggle my toes either. It was a very strange sensation. That's the kind of thing you're talking about, right?
Exactly. So not only do we have to make sure that the patient understands that the extremity or the body part will be numb, but we have to make sure that they don't use it. So, for example, if you're going to be placing a nerve block on the knee or the leg or the foot, we have to make sure that the patient's going to be careful if they try and walk.
Right.
And to the same token, if we give a nerve block to somebody who's having shoulder surgery or hand surgery, be very careful to protect that side of the body. And that's a conversation that we have in length with the patient.
Do you find that this numbness or paralysis lasts so long that it can sometimes interfere with patients' kind of rehabilitation or recovery, or is that really not a thing?
Actually, it's on the contrary. The numbness actually allows patients to participate in achieving their milestones of rehabilitation much earlier than if they didn't have the nerve block. So one of the things that we became really good at, again, watching the field continuously evolve, is the nerve block that we give for either knee or hip surgery. In the past, we would block a nerve that would numb the entire thigh muscle. And as a result, the patient in that respect would have a risk of either buckling their leg and falling. So now what anesthesiologists have evolved to do is perform that nerve block in an area much lower down the knee. So it's actually called the adductor canal block. Patients can research this. It provides equivalent pain relief to the older femoral nerve block, but it's not accompanied by the same level of muscle relaxation that's found in the thigh muscle, and patients are able to walk with significantly less pain right after surgery. And we have a visual of a patient having a knee replacement after surgery and walking in the recovery room.
That's pretty remarkable.
Yep. It's impressive, and it's really a consequence of the continuous evolution that we see in our field.
So let me ask you something related to that, which is the use of follow-up pain medications, because clearly having surgery can hurt, right? I mean, people are left with an incision or disrupted tissues and things like that. So it's not uncommon for people after their anesthesia wears off to need pain medication. How big an impact does this regional approach have on the need for postoperative pain management?
Yeah, so what a spectacular question, and that's really what's made the field of anesthesiology so, number one, impactful, painful, and number two, fun, because never before have anesthesiologists been able to partner with our surgical colleagues to really impact what the post-operative course can look like for a patient. So in the old days, and I'm talking 15, 20, 25 years ago, it would be typical for a patient to receive enough pain medication for 30 days. A very large dose of pain medication. Now, because of these regional nerve blocks, where patients are given significant pain relief for up to 36 hours, which is, by the way, the most painful or provocative part of the surgery. If we can get patients through that first 36 hours without needing a significant number of doses of pain medication, then we could impact how much pain medication they take, and we could also impact the entire postoperative experience. And that's what the field of regional anesthesia has done for us.
And could you just remind our listeners why it's so important to limit that amount of postoperative pain medication?
So again, we talk about the concepts of addiction, and really what we're talking about is first getting dependent on the medication. And we have studies that show that patients can develop first a tolerance and then a dependence on pain medication in as little as 3 to 4 days.
Wow.
So it's important. It's real. It happens. And part of the challenge of why we have an opioid epidemic is because we, as the practitioners, haven't been as diligent and vigilant as we could be when it comes to prescribing pain medication. Now, the entire medical landscape is aware of this challenge, and we're all working together to, number one, inform patients of the risk. Number two, develop techniques to reduce the need for pain medication. And by the way, communication is always right. Our first salvo. So that's what we're trying to do.
Yeah. So you've described some really interesting innovations. Where's the field going next? What's coming down the pipe?
Nirvana for us is to perform a surgical procedure where a patient will not only have zero pain, but they'll also not have any numbness. And it's only a matter of time before some really smart research and development scientists create a Novocaine that will be specific for blocking only the pain part of the nerve and not the muscle relaxation part of the nerve. And when that happens, we're going to be able to administer a Novocaine, which will just block the pain impulses. The patient will have total use of their extremity without the need for pain medication. And that's what Nirvana looks like for us. My guess is that's a little bit away. What is not that far away is the use of the really long-acting Novocaines. So we could give patients pain relief beyond that 24 to 36-hour time frame.
Yeah, wow, that's very exciting stuff. So if any of our listeners are interested in learning more about all of the things that we covered today, where would you direct them to look?
So, what we tell our residents and our medical students is YouTube. You could YouTube any topic, anything at all. If you go on our Northwell anesthesiology website, we have some patient information there about, the use of nerve blocks to decrease pain medication, and also some of the anesthetic alternatives that we do have. But without question, Google search, YouTube, and inform yourself of your anesthetic options, and please come and ask your anesthesiologist what impact they could have to improve your experience.
Joe, thank you so much.
Ira, it's always a pleasure. Be safe, and thank you for the opportunity. Bye-bye.
My pleasure. So my guest today has been Dr. Joseph Marino. He's the Senior Vice President of Northwell Anesthesia and an Associate Professor of Anesthesiology at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.